Welcome everyone to today's talk on sleep medicine. My name is Dr. Andrew Ng. I'm a respiratory and sleep physician based in Sydney. My medical degree is from Sydney University and my PhD in sleep medicine is from the New South Wales University. I also run a postgraduate sleep medicine course based at University of Western Australia. Last week I discussed non-REM parasomnias, which occur in slow wave sleep and commonly occur in children, with most children growing out of them by adulthood. I highlighted two cases in adults who presumably did not grow out of them, called homicidal sleepwalking, which is very rare. The 19th century Boston case involved Mr. Tyrrell killing Miss Bickford, whilst sleepwalking, and the 20th century Canadian case involved Mr. Parks, sleep driving 20 kilometres in order to kill his mother-in-law. Whilst you may find these cases hard to believe, as do many sleep specialists, particularly given the complex behaviours demonstrated, such as setting fire to the brothel in Mr. Tyrrell's case, or opening his in-laws' house with a key in one hand whilst holding a tyre wrench in the other in Mr. Park's case, which are not classical of non-REM parasomnias. Nevertheless, the juries found that a non-REM parasomnia was not impossible. I've also had questions from some of my subscribers regarding my first sleep talk. How did sleep deprivation lead to the Space Shuttle Challenger tragedy and the Chernobyl nuclear disaster? The answer is the repeated poor decision making by senior managers who had been working round the clock with minimal sleep, particularly in the days leading up to the disaster, which led to a combination of events known as the Swiss cheese model of accident causation. This model, formulated by Mr. James Reason, is used extensively in risk analysis and risk management in aviation safety, engineering, healthcare, emergency services, computer security, etc. One poor decision or issue on its own generally does not lead to a catastrophic failure. Rather, major disasters are a cumulative effect. Last week, I left you with this picture, which demonstrates today's topic. And you guessed it, today the topic is obstructive sleep apnea. In fact, I suspect everyone in this photo would be at high risk of obstructive sleep apnea, even including the referee, who may be thin, but is likely to have dentofacial characteristics which predispose him, such as the adenoid or long face. Obstructive sleep apnea is characteristically worse during REM sleep, which occurs more during the second half of the night. The main character in this picture is Andre the Giant, a professional wrestler with acromegaly, or more correctly, gigantism, as his epiphyses had not fused when he experienced supranormal levels of growth hormone from a pituitary tumour. This causes many things, one of which is a large tongue. Ordinarily, the space in the upper airway is quite limited. If the tongue is overly large, one could imagine that the space would be nearly zero. This is also the case seen with King Kong Bundy, who is 460 pounds. This leads to an increase in pharyngeal fat pads, a larger tongue, and a significant reduction in upper airway space. This is what occurs during obstructive sleep apnea. When awake, the muscle tone of the upper airway is sufficient for it to remain open and patent. During sleep, however, muscles also go to sleep, and the upper airway can become virtually blocked, as in the second picture here, which indicates snoring, or completely blocked, as seen in the third picture, which indicates an obstructive apnea, where no air or oxygen can get in. This can happen repeatedly during sleep, leading to poor sleep quality and a range of symptoms, as outlined in this diagram. At night, symptoms include snoring, breathing pauses known as apneas, choking or gasping for air, restless sleep, frequent bathroom visits to pass urine, and during the day, waking headaches, daytime sleepiness, poor concentration, irritability, and falling asleep during activities such as driving, which has medico-legal implications, just to name a few symptoms. The effects on the body are also wide-ranging, as seen in this diagram, from stroke, multiple heart conditions, mood disturbance, diabetes, obesity, gastric reflux, etc. Obstructive sleep apnea is generally diagnosed with a sleep study, either in the laboratory or at home. Treatment is varied and depends on the severity and comorbidities of the patient, ranging from more conservative measures such as weight loss, avoiding sleeping on one's back, avoiding alcohol, smoking and sleeping tablets, maintaining good sleep hygiene, which includes things like regular sleep times and sufficient sleep, adenotonsillectomy or orthodontic treatment in appropriate cases, various other surgical options, dental devices known as mandibular advancement splints, and the gold standard treatment of CPAP therapy, known as continuous positive airway pressure, which abolishes hypopneas and apneas, abolishes snoring, improves sleepiness, improves neuropsychologic functioning, and improves blood pressure to a degree. Well, that was a quick run through of obstructive sleep apnea. If you are interested, there will be a more detailed talk on this later on. In the meantime, if you have any questions or topics that you would like discussed, please feel free to leave a comment and/or subscribe. As usual, I will leave you with one last picture which I will discuss next week. Bye for now.